This info bit is on the gastric bypass and duodenal switch. These procedures are malabsorptive procedures. These are slightly more complicated than restrictive procedures because we not only reduce the size of your stomach, but we also bypass some small intestine. This leads to absorption of fewer calories. So in addition to eating smaller portions, you're not absorbing all the calories you consume. So they're more powerful procedures, and overall, they'll typically have the best long-term weight loss, but since they are more complicated procedures, they come at a slightly higher risk. Here's a graphic of a gastric bypass, and if you take a look at what we do here, we disconnect this small part at the top of the stomach, and we call that the gastric pouch. We disconnect that from the majority of the stomach, and then we take the small intestine, which starts right here, and about 2 feet downstream, we divide that small intestine, and we pull that up, and we attach it here to the gastric pouch, so that when you eat after a gastric bypass, the food comes down your esophagus into this pouch, and you don't have to fill up your entire stomach to feel full. You only have to fill up this gastric pouch. So obviously your portion sizes will be smaller. And then the food will pass directly into the small intestine, but it won't mix together with any of the digestive enzymes because those are all produced here at the beginning of this part of the intestine. So again, that food is traveling down, doesn't mix with the digestive enzymes until this connection here, and then it gets absorbed normally downstream. So roughly 20% of a patient's small intestine will get bypassed during a gastric bypass procedure, and so theoretically they'll absorb 20% fewer calories. With the duodenal switch, it's kind of similar, except we're actually doing a sleeve gastrectomy, and then we are taking the small intestine and bypassing it down to this component here. And usually with a duodenal switch, much more intestine gets bypassed, which can lead to even greater weight loss than a gastric bypass, but also can lead to some long-term nutritional and nutritional and vitamin deficiencies. Similar to the other procedures, these operations are also done with a laparoscopic, minimally invasive technique. So this is going to minimize your postoperative pain, speed along your recovery, and reduce potential complications. The operation time for these operations is a little longer than it is for sleeve and lap band. Usually they take about an hour and a half to 2 hours. The facility stay is also a little bit longer, usually 24 to 48 hours. And it's important to point out that with these operations, since we are bypassing some of your small intestine, your long-term office visits and vitamin supplementation is going to be critical after these operations in order to avoid any nutrient deficiencies down the road. Risks of gastric bypass and duodenal switch are somewhat the same as for sleeve. We did talk about the risk of bleeding, the potential of staple line leaks, also with sleeve gastrectomy, and these are similar risks that we see with gastric bypass and duodenal switch. However, there are some potential additional risks. Because of the work we do on the small intestine, there is the potential down the road for what we call an internal hernia, which involves a herniation of the small intestine. Gastric bypass patients can be at risk for an ulcer at that connection that I showed you between the gastric pouch and the small intestine. And I've mentioned this a few times, but just to point out again that the potential for vitamin and nutrient deficiencies is going to be higher after a gastric bypass or duodenal switch because of the bypassed small intestine. Recovery, though, is fairly similar. Typically, patients will take a week or two off work unless you have a heavy lifting, strenuous type of job. And we advance your diet after these operations similarly to what we looked at for gastric sleeve, where there will be 7 days of a liquid diet, 3 weeks of a pureed diet, soft solids then at the beginning of the 4th week and thereafter. Our bypass and duodenal switch patients usually come in about 5 times for office visits in the first year, usually once or twice in the second year, and then yearly thereafter.